Welcome to Sirens Stethoscopes. Today we are talking about paralytics, so let's get into it. All right, welcome back into it. I'm your host, Kevin. Joining me today is Christina. Thanks for joining us.
Hi, guys.
We're going to talk about some paralytics, some medication choices, some compare-contrast, one of my favorite activities to do. But first, let's hear about you. Why don't you tell us about you, Christina?
My name's Christina Cruz. I've been with the Sugar Land Fire Department for 3.5 years now, almost 4 years. I rookied at Station 2 on B shift, and I was at 1, where I spent a couple years. Got a couple of decent calls in under my belt. So I've been a paramedic probably for 6 years now. So
Nice. Yeah. Well, good. Thanks for joining us today. I'm excited about having this conversation.
yeah, me too.
So, we're talking about paralytics. And, there's a few choices, but we're going to narrow this down to two. We're talking about Sux and Roc, so that we have depolarizing and non-depolarizing, because that's really our categorical difference that we're comparing. And let's start with comparing these. What are some things that are the same about these, and what are some things that are different?
So kind of to hit the two things, they're both going to be paralytics, obviously, right? One is non-depolarizing and the other is depolarizing, which meaning one connects to the ACH receptors and constantly makes it depolarize, which that's succinylcholine, that's the depolarizing one. And then your non-depolarizing is it prevents it from even making contact with those receptors,
Nice.
which prevents muscle contraction.
Okay.
So
Let's jump in our little chart here, because we talk about it. Sux holds us in a depolarized state. What are some of the side effects we're worried about that come with depolarizing and then holding it as depolarizing?
So they're called fasciculations, so like muscle spasms, which could cause vomiting. It can actually cause intracranial pressure as well. So kind of things that we want to avoid and not have the patient, have long-term effects, respiratory sicknesses from this.
So not with Roc, though. We don't get
Not
this
with
kind of
Roc.
stuff with Roc. Okay. So non-depolarized. So really, the depolarization is what gives us some of these things, and we hold on to non-depolarizing. There's another big one with Sux, that when we depolarize, that's what pushes potassium out of the cell, just in the regular cycle. So we hear a lot about hyperkalemia and renal patients, or even big multi-system trauma patients that we're worried about this volume of potassium, and then we just add to it with Sux. So what about onset time and duration? These are a couple differences between these two also.
So the onset times are pretty close to the same, but our duration is the big thing, right? So Roc is 30 minutes to an hour, whereas succinylcholine is actually like 4 to 6 minutes. So with us, we'd have to be redosing with succinylcholine, which really is not really conducive for us, especially for transporting all the way to the med center. That's a bit of a drive for us, so it kind of makes more sense for us to use the Roc because it lasts longer.
I agree. So spoiler alert, the answer is Rocuronium for us. And we're going to spend some time talking about some more of the whys, right? So like you talked about, the duration's important to us. We're not really going to outlast the paralysis, which is fantastic. Paralyzed patients are easier to ventilate. When we know that, that's going to be a really easy vent setup compared to the spontaneously breathing patient. And full disclosure, the hospital loves using Sux. And there's a couple good things and a couple arguments. And one of their arguments is that it is such a short duration. So if the airway is difficult to get, they'll start breathing again on their own in just a few minutes. And tell us your thoughts on that one from a field perspective.
So in the field, when we decide that we need it, we need it. Need it now or yesterday. Like, we've exhausted all of our efforts, our treatments, and now this patient's at the point of they're going to die unless they get intubated. So we don't really have the option of it's a difficult airway, we'll just start breathing on their own again.
Let's hope.
Yeah, it's kind of a
And in fact,
thing we have to do.
we hit this airway that we just can't intubate. We can't oxygenate. What's our next escalation?
Our next one is a surgical cric. So.
And how do you feel about doing a surgical airway on somebody who is fully neuro intact and able to start swinging at you and fight against this, right?
No, I mean, that ethically, that would be terrible.
Hopefully this person's kind of got this reduced mentation that they're not aware of a lot of this stuff. But let's remember there's a lot of reflexes. There's lower brain stuff that is designed to not consciously think about responses and just protect itself. So if we paralyze somebody, we have to escalate through our airway procedures and we end up at this surgical procedure. Like, yeah, absolutely. I would like the anatomy to not move anymore on its own than it's going to with me pushing it around. So the duration there, you're right. We're not in a comfortable spot of, let's see if we get an airway.
Yeah.
Let's see how it. No, we're kind of committed. We lean in. Let's talk about the duration of Roc is long. We pair it with ketamine. Let's take a minute and point this one out, that the duration of ketamine is not the same as Roc, right? So if our goal with Roc is to paralyze, our goal with ketamine is to sedate and make comfortable. This paralyzed patient can't tell you this is uncomfortable, right? So if I say give somebody a lot of ketamine, what might be a concern that any person's going to do if we give them too much ketamine?
So you're going to have, you come with your ketamine in your larger doses, you're going to have the visual effects and, hallucinations and everything like that. But especially with our shock patients, if we're just saying, hey, give them a lot of ketamine and they don't have the reserves, the catecholamines and the reserves, you're basically depleting them. And then you're saying, oh, we're just going to give them more ketamine and it's going to make them bottom out. And then that's going to.
We'll dig into some of the shock stuff too, but right, it's important to pay attention to the comfort piece, right? Like I said, this person might be like, oh, hey, it hurts again. Can I get some more medicine? So that's kind of on us to keep people comfortable. But let's start talking about some of the shock stuff. So you had mentioned our catecholamine uptake, our depleted people. How do we adjust our dosing if we're worried about this person's hemodynamics?
So our normal dosing for a stable patient is 100 milligrams of ketamine. So we just half it. So we 50 milligrams, and then we're going to up our rocuronium dose, 150 to 200 milligrams.
Right. So. And what are the effects of ketamine that we're worried about in these shock patients? What does it do with the heart? What are we hoping the catecholamines come do? Tell us more about that one.
So we're worried about the effects of blood pressure. So really with any RSI, you're going to kind of lower blood pressure and stuff like that. So if they're already hemodynamically unstable and you lower the blood pressure more, then they have the chance of coding on you.
And you make a good point that when we breathe, we got this negative pressure in the chest that helps fill up the heart. And the chest wall moving kind of out of the way. But we have this person who we lay down, we sedate them, we paralyze their chest wall, and now we don't have the negative pressure helping fill, and we have the weight of the chest kind of sitting there on top of things that we really make the heart work a little bit harder, period. Even when we're dealing with the stroke, that hemodynamics aren't a concern. What are some of your thoughts on, even in a not hemodynamically compromised patient, what are some preparations that come to your mind that it's not just, we'll give them ketamine Roc, they're fine, let's go? How are you preparing to navigate some of these changes that we're anticipating?
So definitely making sure you have your pressors hung and ready to go. Even maybe you might need to give them some fluid beforehand or some pressors beforehand, maybe to get their blood pressure up, get them a little more on the stable side before you do give them those medications. But just having everything set up, your tube ready, your suction ready, having your roll call, everyone's ready to go. They know their role and know their dosages and what everyone's supposed to do.
Nice. Do you feel good with kind of pre-medicating ahead of sedation? Not a terrible idea.
Yeah.
Let's talk about the patient who's very very clearly needs pressors and resuscitation. We need to do this resuscitate before intubate. We got to build this person up. What if I take this person, I get them some fluids and pressors, and they're in a really good spot now, and I think they can tolerate ketamine and roc because we've built them back up. So I just blast them with ketamine, like 100 and 100, right? No problem whatsoever because their blood pressure's fine now, right?
So actually, they would still be considered a shock patient. So they started off as a shock patient. They're still considered a shock patient. So just because we got them up with what we gave them, we don't want to backtrack and lose all of our process of, where we have them at. So.
I got you. So we stand to undo all of this hard work just because, like, the book says this number is fine and we're above it. So just right. Well, let's not forget the goal of ketamine is to make somebody comfortable and unaware of the stuff going on. And if their GCS is already 3, right, do we really need a full 100 of ketamine? If they're a shock patient, then we definitely don't need a full 100 of ketamine. Mm-hmm. Shock works as an anesthetic, also reducing augmentation. So, I love it. Let's take this person who is unconscious, and it's maybe they don't need a full 100 of ketamine. So we give them 50, and not because their blood pressure is soft, but just because, their GCS is 3. They don't need a full 100. Do we still need to give that person paralytics if they're unconscious and they look like they're pretty good?
Yeah, so you still want to give the paralytics because they still might have a gag reflex. So if you go to intubate and you
get a
stimulate the gag reflex, you could vomiting, aspiration, and then, like I said, they're in the hospital long term with possible pneumonia, so it makes their recovery time a little bit longer. Again,
right? These lower brain reflexes are there. And the last thing we want to do is irritate the throat. We get a laryngospasm that we could have prevented, and now we got to come back out of the throat. We got to try and oxygenate some more. And so, right. If we're going to do it, let's do it right.
Correct, yeah.
Right? Do it right the first time. Awesome. Let me make sure I'm not missing stuff on the notes here. There's a whole lot of literature that talks about intubations are just easier with paralytics, right? And some of the time, one of our big things with RSI is that some of these intubations start coming off as kind of elective. That do we really need to tube? Right, but we go with this person's clinical course that they're going to need a tube. The stroke's going to need a tube to go in the scanner and go into surgery. And if we can effectively do it, let's go ahead and manage that.
Yeah.
One of our challenges becomes trauma patients, that we have our blood now, but as we resuscitate trauma patients, we build them back up. We sometimes alleviate the need for a tube in the first place, that we get them awake and talking to us. But it's kind of a profound thing. It's kind of a scary thing, but it's kind of an awesome thing. You can go paralyze somebody's body and his neurons don't fire. I think it's kind of terrifying. I don't know about you.
Yeah.
Feel good about it. You're like, let's just go do it. Have a good weekend with it.
Yeah.
But, right. So we got our rock. We got our differences. We talked about sucks good in some spots, not really good for us. Like, we need to be there. We need to lean in, and we really go to town. How about a paralyzed patient on the ventilator? Would you rather have the spontaneously breathing patient that is tubed that you're trying to be on the vent, or this person's paralyzed and you have full control?
No, the person paralyzed has full control, 100%.
Right? Some of them make it difficult enough as it is.
Yeah, absolutely.
Man, well, I love it. I think this is a good review of the medications, why we're in the choices that we're in, and just the benefits we get from it. You got any thoughts, ideas, or concerns about paralytics, RSI in general? Any closing comments you want to throw in?
No, I think we pretty much covered it. I know when we're at that point of RSI, we're at that point, there's no turning back. Like, we've exhausted all of our efforts up to this point.
Mm-hmm.
So,
you know what? I am going to throw one more fun discussion point at you. Ketamine roc for RSI. Ketamine first, roc first. What are your thoughts? realizing that there's not really an exact right answer that applies to everything. But
Yeah. I mean, I don't know. I guess.
I think this one's a solid it depends,
Yeah.
right? If we get the respiratory failure patient who's awake looking at you, they're probably going to get ketamine first, right? We've had a couple head traumas and strokes. Actually, the head trauma was the big one. Roc was before the ketamine. That we needed the paralysis to set in more than we needed some of the comfort stuff because that was just the GCS that was there. We give these in pretty close succession, though. So it's kind of, not like a big difference. But it's called rapid sequence induction. But how fast is all this really happening?
I mean, the whole process itself is going to be, it's a longer process than you would think. It's not a big rush. We're not rushing to put the tube down someone's throat. We're making sure everything's set up and then everyone's set up and aware, and then we're going with the procedure. So.
Okay. I feel like that's a good closing point there. Like the rapid part is getting the effect of the medications and not rushing through this procedure.
Yes.
So, all right. Well, Christina, thank you for coming on. Thanks for having a discussion. Did we get everything?
Yeah, I believe so.
Okay. Awesome. Well, thanks for tuning in, and we'll catch you for the next one.